The Admissions and Transitions Optimization Program is an initiative through Health Insight Nevada to reduce avoidable hospitalizations among long-term care nursing facility residents. The initiative is funded by the CMS Innovation Center. Health Insight is a private, nonprofit, community-based organization dedicated to improving health and healthcare. It operates in 5 western states, including Nevada, New Mexico, California, Oregon, and Utah. In Nevada, in addition to the ATOP program, Health Insight is the CMS-designated quality improvement organization. It manages the statewide health information exchange and operates several other quality improvement-related programs. Health Insight Nevada was selected by CMS as one of 7 organizations across the nation to lead the initiative to reduce avoidable hospitalizations among nursing facility residents. In September of 2012, Health Insight launched the Admissions and Transitions Optimization Program, or ATOP. ATOP focused on education and utilization of proven quality improvement methodologies, such as the Interact tools, in 24 nursing facilities throughout Nevada. Health Insight Nevada's ATOP program has recently been awarded Phase 2 by CMS through 2020. ATOP will continue the clinical intervention in Nevada facilities and introduce a new payment reform model. The payment reform model is also being tested in a group of comparison facilities located within Colorado. The model is marked by the addition of new billing codes and payment rules aimed at both long-term care facilities and providers. In Nevada, we will continue working with the 24 facilities involved in Phase 1 and will be recruiting all eligible practitioners. In Colorado, we will be recruiting approximately 24 facilities and eligible practitioners to participate in the second phase of the initiative. To be eligible to participate in Colorado, facilities must have an average daily census of greater than 80 residents with greater than 40% of the total long-term care facility census as long-stay Medicare enrollees in traditional fee-for-service Medicare, and have at least a 3-star overall rating on Nursing Home Compare on the date of this funding opportunity announcement, August 27th of 2015. Facilities must also not be on the CMS list of special focus facilities, have no survey deficiencies for immediate jeopardy to resident health or safety within the last 12 months, not had any sanctions, indictments, probations, corrective action plans, or judgments imposed in the last 3 years relating to fraudulent or abusive billing practices, and be Medicare and Medicaid certified and not excluded from participation in the Medicare or Medicaid programs. To continue participation in the initiative in Nevada, a facility must have participated in Phase 1 of the ATOP program, not be on the CMS list of special focus facilities, not had any sanctions, indictments, probations, corrective action plans, or judgments imposed in the last 3 years relating to fraudulent or abusive billing practices, and be Medicare and Medicaid certified and not excluded from participation in the Medicare or Medicaid programs. Phase 2 looks to reimburse both long-term care facilities and practitioners to treat certain conditions in-house rather than admitting the resident to an acute care setting. Therefore, the new payment model is designed to add new billing codes for facilities who treat patients for the 6 qualifying conditions, increase practitioner reimbursement rates for treating beneficiaries in a long-term care facility rather than transferring to an acute care setting, and reimburse practitioners for their participation in patient care conferences. 6 conditions will be considered under the payment reform model: pneumonia, dehydration, congestive heart failure, urinary tract infection, skin ulcer and cellulitis, and COPD and asthma. Only these 6 conditions are contemplated under the new payment reform model. The new billing code, designed to equalize payment to facilities, should encourage additional time and resources, beyond what is required today, to furnish services and treat beneficiaries in-house without transferring to the hospital. There are 3 components to the payment reform model: 1 that pertains to the participating facility, and 2 that pertain to the practitioners. Payment to a facility for treatment in-house of any of the 6 qualifying conditions, approximately $218 per beneficiary per day. Payment to a practitioner for treatment of qualifying conditions on-site at the long-term care facility will be the same as those currently received in the acute hospital setting, and payment to practitioners for care coordination and caregiver engagement for beneficiaries. This rule change would cover up to 1 care conference per year. The proposed model would only provide payment to long-term care facilities for the specified increased services to treat the conditions. Payment to the facility is also subject to 4 conditions: confirmation of the qualifying diagnosis and the prescription of treatment by an attending practitioner, duration of benefit. A specific duration of benefit for each of the 6 conditions is applied in the model. Limitation of benefit. None of these codes may be billed more than once a day for a single beneficiary, and no more than one of these codes may be billed in a day for a single beneficiary, even if that beneficiary has more than one of the 6 conditions being treated in the facility. And qualifying criteria. Each of the 6 conditions has qualifying criteria defining the clinical or diagnostic conditions of a beneficiary that could trigger the benefit. For more detail, see ATOP2.org/payment reform. Beneficiaries are considered eligible if they have resided in the long-term care facility for 101 cumulative days or more starting from the resident's date of admission to the facility, are enrolled in Medicare, Part A and Part B fee-for-service and Medicaid, or Medicare Part A and Part B fee-for-service only, have not opted out of participating in this initiative, reside in a Medicare or Medicaid certified long-term care facility bed, are not enrolled in a Medicare managed care plan, and have not elected Medicare hospice. To be considered for participation, eligible facilities will need to submit a letter of intent to participate, a readiness assessment, an agreement upon approval, and a commitment to payment reform initiatives and beneficiary needs. Don't miss this opportunity to be at the forefront of payment reform. To take advantage of these payment incentives or to learn more about ATOP2, email Adriana Mahoney at amahoney@healthinsight.org or call 775-530-4215.